There we go. Excellent. Okay, well, let me get started here.
Hey, we all wore orange, sort of. Orange
Oh,
and
wow. When did that happen?
Look at us.
All
Wow.
right, and you guys can get started.
Okay.
Gabrielle, if you want to kick us off.
Hello?
There we go. Wonderful.
There we go. Thank you. Good afternoon. My name is Gabrielle Jones, and I am CEO of GDK Associates. I just want to start by thanking Georgia Bio for selecting this topic. It is a topic that is near and dear to my heart and an area of community engagement where I am most passionate. As a patient advocate and care supporter of an adult son with a rare autoimmune disease who relies on innovative immunotherapies to keep him healthy, and navigating our healthcare system can be challenging. Like many of us, I spent many years involved in grassroots community engagement, listening and talking with patients, caregivers, community workers, underserved and impoverished communities. And many have expressed a sense of hopelessness, confusion, feelings of being left out as a result of mistrust of the very people that in the institutions that they say should want to care for them and care about their needs. Unlike my son, many of these patients lack the resources and support they need for their care. I know as some of the speakers spoke earlier about health equity and this topic that we've been talking about for many years, I think we're going back to 2000 when the first legislation focusing on reducing health disparities was signed into law by President Clinton. So, but here we are, yet today in the middle of a pandemic and more Black and brown people have disproportionately died from COVID than any other race. While there have been improvements, a lot of improvements, the promise of equal access to quality healthcare and innovative treatments and therapies has not been realized for many Black and brown people who just are trying to survive. Solutions to health equity and access to quality healthcare and inclusion in clinical trials cannot be considered in silo thinking. We must address social and economic conditions that will create such things as pathways to careers rather than simple low wage employment, transportation barriers, childcare, quality affordable housing rather than gentrification. And now with the threat of potential increases in cost of broadband access, poor families will not benefit from such thing as telehealth. We have to go a little deeper into getting to know and treat patients inclusive of their social and economic lives. We must learn to listen to the needs of communities of color, be transparent and accountable. A one-size-fits-all system and approach to care that favors a dominant culture is not acceptable. If we do care and believe we put patients first, we have to go beyond stating that Black and brown lives matter to acknowledging and believing that Black and brown lives actually have value and meaning. Then we can come together in a spirit of collaboration to align our value statements with our actions. We will then go beyond providing just standard of care to considering the reallocation of financial and human resources, creating more culturally competent approaches to chronic disease education and delivery of healthcare, and including patients as collaborators in the creation of inclusion and exclusion criteria for clinical trials. Now I'd like to introduce our guests today. And we'll each go through and then let you tell it a little bit about your organization and your work in the community. So first we have Dr. Jane Morgan, who is Director of Innovation and Clinical Director of the COVID Task Force for Piedmont Healthcare. And by the way, that's where my son gets his care from, and he's doing awesome. So thank you. We also have Linda Blunt, who is the Chief Executive Officer of Black Women's Health Imperative. So we will start with Dr. Morgan. Can you just tell us a little about your work at Piedmont?
Yeah, sure. So in the realm of research and innovation and the COVID task force, I intersect very well with clinical trials. And in fact, my background comes through industry at Abbott and Solvay, in R&D and medical affairs, developing clinical trials, developing drugs, developing devices. And so that is a topic that is near and dear to my heart. And if anyone has ever heard me speak, you've heard me emphasize that if you are with your physician and you have been given every option available that is FDA approved, that has come through evidence-based medicine, then you have been treated optimally. But if you have not been offered a clinical trial, you have not been treated maximally. And we need to understand the difference, and we need to be able to advocate for ourselves, because generally it is our physicians that are disconnected from the academic and medical centers where these clinical trials are being offered. And they also don't serve as principal investigators of trials, which is where patients are being recruited. And then you add into that, all of the atrocities that have been committed against us, not only Tuskegee, but the Gila, the Henrietta Lacks, on and on and on, until there's a reticence and certainly a suspicion of not what is being told to us as we're being given information such that we can decide whether we want to engage or enroll in a clinical trial. But the question in our minds is what are we not being told? And there's that distrust. Here's what you're telling me. I wonder what you're not telling me. That could harm me. So I think the answer is no. I will not be in this clinical trial because I cannot trust that the system has my best interest at heart. And so that is a whole compendium of where I work both inside and outside of Piedmont. Currently with COVID, I am the newly named clinical director of the COVID task force, and we are focused exclusively on looking at the brown and Black communities that we serve, and if we can serve them better and and mitigate this devastation of COVID. So in other words, is there something with the Latinx and African American communities that we may be missing in the emergency room that is different? Should our algorithms have some intrinsic bias? Are there specific areas pathophysiologically that we need to understand? Are there medications that one group may be on more likely than others that may increase your risk or increase your susceptibility? Those types of things. So that's what I'm tasked to really do, a deep dive, look at the data, and provide some recommendations to the system of how can Piedmont be a better community partner with people of color, and also be a better provider of medical therapy, very specific to what the needs may be of different groups when we look at COVID.
That's awesome. You are definitely focused on transparency then in all of this, so appreciate that. Okay, and Linda, can you tell us about your great work at your organization and what you're currently involved in?
Sure. Thank you, Gabrielle, and good morning, Georgia Bio family. Thank you for this opportunity to have this really important conversation. Hopefully this will be the beginning of several conversations. The Black Women's Health Imperative is now in year 38 of being the only national organization focused on Black women's physical, emotional, and financial wellness. We started back when our founder, Billy Avery, brought 2,000 of our closest friends together to Spelman's campus to talk about how we should take care of each other and, most importantly, take care of ourselves. So for 38 years, we've been focused on chronic disease prevention and risk reduction. We all know how the Black and brown population are impacted by chronic diseases, sexual health and reproductive rights and reproductive justice, HIV prevention, and policy undergirds all of our work. We work very closely with the Congressional Black Caucus and the Caucus on Black Women and Girls. We help write some of the legislation that helps promote health supporting policies, and we work very hard to try to defeat health limiting policies. And what I bring in the last 6.5 years that I've been in this role is a focus on research. I'm an epidemiologist, and it is really critical that we understand how we are viewed by researchers, how we participate in research, whether we participate in research, what that means for the everyday Black woman. Because I can tell you, as Dr. Morgan mentioned, the average person has no idea what clinical research is about, what a clinical trial is, to even ask for a clinical trial or know that he or she should be asked to participate. And so we're spending a lot of time trying to educate women, give them the tools, the resources to participate in clinical research, but from a position of value and respect. If that's not happening, then our participation is meaningless. But it also means we've got to work with researchers and providers so they understand what value and respect means for their participants. And I know we'll talk about that a little later, but this is really critical. And what we've seen just recently with COVID-19 is when we don't report the data, when we don't collect data by race and ethnicity, then we cannot have the most effective response to something that is disproportionately affecting this population. So that is our focus now, and making sure that we help women do everything they can do to be as healthy as possible.
Awesome. Thank you. Thank you for that. So Dr. Morgan, you gave a great overview of what you're doing with the task force. And we often use this word, institutional racism and biases, as if the institution is something that is untouchable. But these are actual people that are in place that come with biases, whether intentional or not. But that finds its way into how care is given, limited care, no care, coverage policy, name it. And that, how can we address that? How can we really begin to look more closely and make changes where necessary?
Right. You know, this is such an important area within clinical trials. When we look at, say, the African American population, we are just over 13% of the population, but with clinical trials, we're just under 5% of enrollees, and that includes trials for cancers that disproportionately impact Black Americans. So trials for colon cancer are done on white men. Trials for prostate cancer done on white men. Trials for specific types of breast cancer that are more common in Black women, are more malignant and more aggressive in Black women. We are not in those trials. So what happens is when we develop drugs and therapies, are those drugs and therapies relevant to our clinical course and to our treatment? And I would argue that the answer to that is maybe and maybe not. And that's a tough place to be in medicine, to be treated with a big maybe. And I think we've seen, you know, examples of absolutely when that has not happened, and the FDA has had to pull drugs for anticoagulation and pull other types of medication and put codicils on them when it was found that they actually harmed Black patients in some areas. And those are the types of what we call SAEs, systemic adverse events, meaning side effects. Those are the types of side effects that should come to light during the course of studying the drug, not after the drug is approved and the doctor is prescribing it, and instead of helping their patient, they're harming their patient. That's the purpose of doing the studies early. And I recently wrote a paper critical of the Moderna trial, which is one of the trials that's developing the COVID vaccine, because in their early stage, they enrolled 45 patients. Only 2 of those patients were Black. They had 3 dose groups, about 50 micrograms, 100 micrograms, 250 micrograms for their messenger RNA vaccine. And the only 2 Black patients in the trial were both in the same group. They were both in the 100 microgram group. From that phase, they selected the 2 phases the 2 doses that would move forward to study. Well, in selecting those two doses, I believe they selected the 100 and 250 microgram groups. They selected doses in which, so maybe what I should say is they deselected doses in which Black patients didn't participate at all. So we have no idea whether those were beneficial to us. So they deselected one dose, and then they selected another dose on the higher end, also in which Black patients didn't participate. So who knows if that one is effective. And then the dose in the middle, 100 micrograms, that was also selected, had the 2 African-American patients in them. And ironically, that was the dose that also had the most side effects. And so, you know, these are questions that come to mind to say, you know, are we doing the best that we can for everyone? And do we need to have practices that are different? And, you know, and I think, you know, what the industry has said, and they are changing, is that, well, we don't have, you know, Black people don't enroll in trials. What would you like for us to do? And I think the question is, maybe you need to seek these patients. Maybe there needs to be some type of conversation and acknowledgement of what the history has been, but also include Black physicians who control 80% of Black patients. Most 80% of Black patients in the United States see a Black physician, and Black physicians do not serve as principal investigators of clinical trials. So there's the first stopgap. How do we get our doctors? How do we begin to recruit our doctors? And then in clinical research programs, there is no leadership. There's no African-American leadership. There's no brown or Black leadership. And not only at the mid-management, upper management as well. And so it's very hard to advocate. It's very hard to move these issues up the ladder. People don't see them as important or valuable. And I think it's also difficult if you're at a mid-management level to push against the system. You can only go so far because you only have so much power. And so leadership is incredibly, incredibly important as well.
Yes. My son, his rheumatologist who treats him for his autoimmune disease is Nigerian. His PA is African-American. He gets his care over in Northside. And his doctor, of course, is moving to a rural part of the state. So he's going to be moving to Conyers. My son lives in North Georgia, but it is so important. Shared culture is very important to his care, and he is willing to travel the distance to continue seeing his rheumatologist. So, you know, just personal experience with that. And as his care supporter, I will make sure that he gets what he needs.
And, you know,
Linda.
You make a good point. Just what you're talking about is cultural congruence. And, you know, are we able to speak the language? The language meaning understanding the culture, understanding what's not being said, that if a patient is sitting there and silent or nodding their head, that you know that actually is not an agreement. They are just sort of agreeing to agree to leave the room, but they really haven't agreed. That's cultural. You understand what that meant, that no, you will not be seeing Dr. Morgan again. She nodded her head and she's left the room and she's not coming back.
Right.
So that type of thing. So I think it's important. You're correct.
And Linda, what are some of the biggest lessons learned to better prepare for a healthcare sector in the future? And what do you think are the biggest changes that have occurred, that have come out of the COVID crisis?
Yeah. Well, let's hope we learned something, and let's hope we have learned something. You know, one of the things that concerns me about these trials now and clinical research in general, we talk about evidence-based medicine all the time, but in this case, and in previous many examples, we talk about applying a body of evidence to a population that had nothing to do with its creation in the first place. To Dr. Morgan's point, we didn't have 2 Black patients in a trial is not a sufficient population on which to base a decision. And just so folks know, we have a real life example right now. When it comes to severe COVID-19 illness, dexamethasone has been proven to be effective in some patients, not as effective in African-American patients. There were no Black people in those dexamethasone trials, so it's not surprising. So what I think about, the lessons lessons are, one is what's an appropriate public health response? Because clearly we didn't have one. We did not have a strategic public health response. We started out by not collecting data, so we couldn't apply a testing, contact tracing, isolation strategy to the hardest hit populations because we weren't reporting the data. Some people knew, but we weren't reporting it. We talk, when it comes to COVID-19 and other illnesses, but we talk about the social determinants of health, these underlying chronic diseases that raise the risk of certain populations for infection and severe disease. Well, we need to start with, why are there the social determinants of health in the first place?
Right.
We tend to take them as given. Well, they don't have to be. They should not be given, and we need to ask why they exist. And one of the things that really concerns me is, what we're going to do around inclusion. I mean, as I think most people know, when it comes to clinical trials, there are all these exclusion factors because researchers want to make sure that their participants are otherwise healthy people so they can test the impact of the therapeutic or the vaccine. Well, we need real world examples because most of us are really not otherwise healthy. Most of us have some other sort of what we call comorbid condition, whether it's obesity or diabetes or pre-diabetes, hypertension. We need to make sure that these issues are being factored into our studies. And put a finer point on it, the number one reason Black and brown people don't participate in clinical research is because nobody asks them. Doctors, we talk about provider bias, they make assumptions about what their patients will and will not do, whether or not they'll go, whether or not they'll comply, whether or not they have money, and so they simply don't ask. And we've got some great examples. The uterine fibroid tumor study, led by Charlotte Owens, has 5,000 Black women enrolled. It is possible to do this, but it has to be important, it has to be of value, and we need providers, clinicians, researchers to get out of their social and professional networks to understand how to do recruitment, that it is valuable, and actually to act on that, to diversify their trials. And I'll just end with, sort of the big challenge, a big concern I have about all of this. Health, yes, but I'm really concerned about the emotional wellness toll that COVID-19, the racial tension, and the economic devastation that is occurring is going to have on the Black and brown community. And frankly, the deaths that could result from that. We talk about deaths of despair. We know poverty is responsible for close to 100,000 excess deaths every year. So you add that on top of the deaths from COVID-19, and we're looking at, without a vaccine, a tsunami of avoidable mortality. And I'm really concerned about what that means for the Black and brown community.
Yes, and I'm glad you mentioned that because we have got to, it might be our responsibility to make sure that we write that narrative because people are trying to separate the two. And it's much like slavery. People say, well, it was in the past, but it had the impact and the trauma has been handed down, and it's still playing out in families today, in lives and families today.
This whole epigenetic expression of stress is a real thing, and it affects our health. Yeah.
Yes.
And I think, just adding to the conversation, rolling it back even further, obviously we can just roll this as far as it goes because it's systemic, it's pervasive, it's so normalized throughout every aspect of America until if you push against it, it's seen as unpatriotic.
Right.
That's how normalized and pervasive it is. And so if we roll just this singular conversation back to why aren't people being enrolled? Why aren't African Americans being enrolled into trials? Why aren't Latinx being enrolled into trials? I'm a cardiologist. If you look at me, you should take a very good look. I'm a very rare bird. Maybe some of you have never seen one before, but a Black female cardiologist is incredibly rare in the United States. Black cardiologists in general are just at about 3%. And a Black female cardiologist is less than that in the decimal point. If we look at orthopedic surgeons, females and males are just at 1.2%. So the point that I'm making is when you get outside of primary care, which already is underrepresented, and get into these specialties, and the specialties often are referring patients to trials when we're studying very specific types of things, valve diseases, or specific rheumatologic diseases. These are specialists. Then there's really almost no representation. And it's important for hospitals to begin to not only recruit these types of physicians, but to be able to have programs and sensitivities in place to retain them. Because what happens is you see these rare birds flutter in, and then you see them flutter out because the environment doesn't support them. They don't feel engaged. They don't feel welcome. They don't feel a part of the system. They don't feel empowered. They feel denigrated. There's a lot of marginalization, including in Black scientists. Often there is a concerted effort to marginalize these types of experts who are in your system, and they are not a part of the mainstream executive strata. They are pushed off to special projects, and there is a concerted, when I say intentional, there's intentional parts of institutional racism in healthcare, and there are also unintentional things that have come about through implicit bias. But there is this marginalization that you will see of scientists and experts as well that are relegated to special projects. And those are the kinds of things, as I say, I roll it back. These are the key people who can enroll people in your trials, but they also are fighting to not be marginalized so that they can go into the mainstream, so they can have access to the patients, so they can enroll them in the trials. So it's just, you know, one thing begets the other. Yes.
Right. I could go on because there's so much conversation in this area that has to happen, and we have to get away from people being uncomfortable because we need to talk about these things. It's important. And I think it's important for patients to hear that we are speaking and bringing this to the forefront so that they can be more open, and hopefully that'll help them know that we care about them and we want to address these underlying issues. So we're at our time. Let's continue the conversation. I think this is a topic that needs to stay as part of this group. But thank you both so much. I enjoyed this.
Yeah, thank you.
Thank you.
And we are going to invite the next session, a community roundtable on advocacy and the COVID-19 era. Thank you.
Thank you.
Take care.
Bye.
Bye.